Minglawa, auspicious afternoon to our Honorable Chairperson, Siai Professor Aung, the Speaker, Dr. PIETTE, and all the invited guests. First of all, welcome to our academic symposium about natural progesterone versus synthetic dydrogesterone, efficacy, safety, and patient compliance. My name is Aung, Brand Manager of A Medical Product Limited, will be the master of ceremony for this academic symposium. It is my pleasure to welcome you here this afternoon. I would like to thank all of you for joining us today for this symposium. Before we begin our symposium, let me provide an overview of today's agenda. Agenda 1, opening of the symposium. Agenda 2, opening speech by the Chairperson, Siai Professor Aung. Agenda 3, presentation on natural progesterone versus synthetic dydrogesterone, efficacy, safety, and patient compliance by the speaker, Dr. PIETTE. Agenda 4, question and answer session. Agenda 5, product presentation by Dr. Aung, PR and Product Manager of A Medical Product Limited. Agenda 6, appreciation remark by Ms. Han, Division Head of OTC and Ethical Marketing Department. Agenda 6, Lucky Draw Program. According to the Agenda 1, Academic Symposium on Natural Progesterone versus Synthetic Dydrogesterone, Efficacy, Safety, and Patient Compliance is commenced successfully. To start our symposium, may I humbly invite our Honorable Chairperson, Siai Professor Aung, to deliver the opening remark and leading this academic symposium.
Good afternoon. Good afternoon from Myanmar. I think Brussels is in the morning, isn't it? And I would like to greet and welcome Mr. PIETTE and Mr. Rigard from the Lessons and President of the Myanmar Medical Association, Obs and Gynae Society, Professor Kim Thing, and member of Obs and Gynae Society, and all the other members, family medicine specialists, and general practitioners. We are today going to have a symposium on the natural progesterone and synthetic progesterone, dydrogesterone efficacy, safety, and patient compliance. Well, progesterone, as we all are familiar with the natural and the synthetic one, both used to treat and prepare the uterus and also regulate the cycle in the gynecology, especially starting in the assisted reproductive technique, preparing the uterus for the implantation, and then support, and then early pregnancy and first and mid-second trimester, threatened miscarriage, and also the preterm labor. Experience to us on the field. Mr. PIETTE was born in the Anderlecht, Brussels, Belgium, graduated in pharmacy in 1975 with a great distinction. Postgraduate training and in the clinical chemistry, bacteriology, and hematology in 1979 with a great distinction also from the Free University of Brussels and ULB. Also had a special training courses, hematology, chemistry, and endocrinology and microbiology. Aborted Hospital, Radio Immunoassay, RIA, and National Anti-Gift Centrum. He is an experienced pharmacist, postgraduate in clinical endocrinology, now specializing in men's and women's health, pharmaceutical development, care, and counseling, and extensive knowledge relative to the men's and women's healthcare pharmaceutical environment. In addition, an expertise in the training and education program development, speakers at the PRISM and PRISM's International School. Recent publication and review on the subject of the menopause, luteal phase support in the ART, and women and late onset of hypogonadism in men. He is also the faculty member and speaker of all allied associations and organizations. He has published 9 publications. So shall we listen to his talk and his experience on the progesterone and progestin? I would like to thank AA Products Limited for supporting this symposium for us. Thank you very much. So may I call upon Mr. Paul Pete to share your knowledge with us.
Aung, thank you so much for this nice introduction. And it's my pleasure to share my experience on progesterone and synthetic dydrogesterone. I want to thank the organizing committee and the company for inviting me to this webinar. So let's share my screen, and so we can start this training course. So the title of my webinar today will address the differences between natural progesterone versus synthetic dydrogesterone, efficacy, safety, and patient compliance. This is my financial disclosure slide, and I am a medical science expert and part of the faculty of the International Price School located in Florence. So let's move first on some basic science information, very important to understand the differences between progestogens, natural progesterone, or synthetic ones. And if you look at pregnancy maintenance in general, you can see that progesterone is needed throughout the whole pregnancy. You can see on the right here the evolution of progesterone blood level throughout the pregnancy. And it's misleading information to believe that you need only progesterone for implantation. In fact, you need progesterone to support the pregnancy during the 9 months of gestation. And you can see that consistently and constantly, progesterone serum levels are increasing, but with a huge inter-individual variation. And that's important to know for your monitoring. We will come back later on this aspect. So you need, from this cartoon from Rai in the Lancet 2006, you need progesterone even before pregnancy, for conception. If you don't have regular cycles, you cannot be pregnant. And progesterone is able to regulate the cycle. If a woman has a luteal phase deficiency with irregular cycle, by giving progesterone, for example, oral capsules, 100 milligram in the morning and 200 milligram at bedtime for 10 days a month, from day 17 to day 26, you regulate the cycle, and so the woman will know exactly more or less a day of ovulation, and she will conceive more easily. But as a professor in the introduction was mentioning, progesterone is a crucial role in implantation, and we now use as a golden standard vaginal progesterone to favor implantation in control ovarian stimulated cycles for ART. But nowadays, and based on recent data that I will share with you, we know also that progesterone plays a crucial role to maintain pregnancy and to avoid any early or late miscarriage. We are working now also to try to demonstrate how progesterone works for the prevention of preeclampsia or for the prevention of intrauterine growth restriction. But what we know since about 10 years is that progesterone works fantastically well, vaginal progesterone capsules, 200 milligrams a day, for the prevention of preterm birth in women at risk for a preterm delivery, women, for example, with a history of a previous preterm birth or a short cervix measured at mid-gestation. So the major clinical indications for vaginal natural progesterone are the luteal phase support in ART, the threatened and the recurrent miscarriage prevention, and the prevention of preterm birth. So you can see that you need progesterone from conception to birth. And the reason why is that progesterone plays a crucial role in several aspects of pregnancy maintenance. First of all, and you can see on this nice cartoon from the New England Journal 2001 by Norwich, that in fact, a first signal once the embryo, the trophoblast, is implantating into the uterus, you can see that the trophoblast will form a signal and production of ACG, and the chorionic gonadotrophin hormone will stimulate the corpus luteum into the ovaries, and that's the corpus luteum, that's the place in the ovaries where progesterone is produced. And you can see that progesterone will increase immediately once you have this implantation process in place. And progesterone plays a very important role to regulate the prostaglandin production. It stimulates the vascular endothelial growth factor, producing new vessels, all those new vessels who will be crucial to feed the trophoblast, to feed the embryo. So progesterone in the first stage is promoting the local vasodilatation and the uterine musculature quiescence by inducing nitric oxide synthesis and the decidua. But on the other hand, also progesterone plays a crucial role in the modulating the maternal immune response. And that's important because if you don't modulate the maternal immune response, the woman will reject the baby considered as an allograft. So importantly, progesterone will facilitate the immune response. It will also decrease the uterine contractility, and that's important also to take into consideration, improving the uteroplacental circulation, favoring the blood circulation in between the mother, the uterus, the placenta, and the embryo. And at the end of the day, progesterone suppresses the fetal inflammatory response. Because in fact, and you will see that in the biological plausibility supporting the efficacy of progesterone in preventing preterm birth, progesterone works as a fantastic physiological anti-inflammatory hormone. And a delivery is no more, no lesser than an inflammation of the cervix. And if this inflammation of the cervix occurs too early, you have a preterm delivery because inflammation of the cervix. As long as you give enough progesterone at the tissue level into the cervix, there is no possible preterm delivery because progesterone has a fantastic anti-inflammatory effect. So important to take into consideration. But what's quite relatively new and demonstrated by the group of Bouchard and Schumacher in Paris 2014 is that the brain tissue has also the full equipment to produce progesterone. So progesterone is not only produced into the ovaries, but you can produce in the brain a lot of progesterone with the same biosynthetic pathway from cholesterol, because the brain has all the enzymes that you need to produce progesterone. But what's quite unique in the brain is that you have a further reduction of the 5-alpha dihydroprogesterone into allopregnanolone. And allopregnanolone is a key hormone because it works as an anxiolytic, an antidepressant, even if it's a very high dose production, an anticonvulsivant. But the anxiolytic effect of progesterone through allopregnanolone metabolism is important during all pregnancy, because stress is an important risk factor for losing a baby during pregnancy. So the anxiolytic effect of progesterone produced into the brain is important to block the stress induced by certainly a first pregnancy. So, and that's unique for progesterone. You don't have this effect with synthetic progestogens. So progesterone is crucial throughout the whole pregnancy, but you have to look at several aspects. The importance of the molecule, the importance of the route of administration, the importance of the formulation, because there are several possible vaginal progesterone available on the market, and for sure, patient convenience and cost effectiveness. But probably the most important during pregnancy is to address the safety issue, because the first thing to think about when you give any intervention during pregnancy is to be safe. And safety is an important point to differentiate progestogens available for pregnancy management. And that was nicely summarized in this review paper that I published in the YBU journal, the Best Practice Research Clinical Obstetrical and Gynaecology, the UK journal, about pharmacodynamics and safety of natural progesterone. And I was mentioning in this article that progesterone has a unique pharmacodynamic profile with a safety profile depending the route of administration. You don't have the same safety for progestogens depending the route of administration, but for sure, the nature was selecting natural progesterone and not synthetic progestogens to maintain pregnancy. So different progestogens may differ in their hormonal activity versus micronized natural progesterone, depending the structure, the tissue concentration, but also the blood concentration. And you will see that very small differences in the molecule. Progesterone is a flat molecule. You don't have here a double liaison. And the number of atomic carbon atoms are not the same in both molecules. Dydrogesterone is a truncated molecule. So depending the structure, you will have a specific metabolism, and the specific metabolism will lead to the production of unique metabolites with a unique pharmacological activity. That's why you cannot compare the activity, the pharmacodynamic activity of natural progesterone with synthetic progestogens. And micronized progesterone has the same chemical formula and configuration as the one produced by the ovaries, which is not the case of dydrogesterone, which is a chemically modified molecule, so named retroprogesterone, but its hormonal pattern and the metabolism differ largely from that of the natural progesterone as it was published by Kuhl in Endocrinology 2011 and by Regine Citricruer, the previous director of the Population Council in the US, Human Reproduction Update 2006. So small structural changes in the configuration of the parent steroid molecule will induce considerable differences in the activity of the derivative. And what's important to keep in mind is that not only the tissue concentration, but the binding affinity of the active ingredient, progesterone versus dydrogesterone, are crucial to define the pharmacodynamic profile. And you can see, for example, I put three important differences between progesterone and dydrogesterone. Progesterone is a slightly anti-androgenic progestin, which is very important for the metabolic neutrality. It has also a diuretic effect, and that for pregnancy maintenance is crucial, because during pregnancy, estradiol is increasing quite more than progesterone, and you need progesterone to counteract the water retention induced by estrogen and to prevent hypertension. So the role of natural progesterone being an anti-mineralocorticoid drug, a diuretic drug, is crucial for pregnancy. And as I was mentioning, progesterone will bind the GABA receptor through the metabolism in allopregnanolone. So all key differences between synthetic progesterone like dydrogesterone, who doesn't bind the same receptors. So progesterone has an optimal metabolic profile and a neutrality. It's a diuretic and it works on the central nervous system. And that was nice summarized in this cartoon. But what's important to see in this cartoon is that not only progesterone, but the metabolites, and there are about 10 or 20 metabolites of progesterone, all participate to the activity of progesterone, binding not only the receptors, the classical genomic pathway, but also binding membrane receptors. And that's also important in pregnancy, and that's unique with progesterone. You don't have this effect with synthetic progestogens like dydrogesterone. You have a membrane effective effect, which takes a few seconds. And I will tell you, for example, that we discovered recently that this membrane effect, for example, can be very crucial to decrease the uterine contractility during the implantation process. So by increasing progesterone very early in pregnancy, and that's why you have to start your progesterone treatment very early during the implantation process, you reduce the uterine contractility and you will decrease the risk of an ectopic pregnancy. So this effect happens in a few minutes through a membrane receptor activity. But we know that progesterone is important for implantation by promoting the trophoblast invasion. And it's a very complicated mechanism to have an optimal trophoblast invasion. And again, you will see that when you compare face-to-face progesterone and dydrogesterone, for example, you don't have exactly the same effect in terms of trophoblast invasion based on the measure of the pulsatility of the arteries, the ovarian arteries, which is the resistance index that you can measure by ultrasound, which is quite different by administering progesterone or dydrogesterone. As I was mentioning, progesterone will improve the uteroplacental circulation, but importantly for the prevention of preterm birth, it will keep the uterine quiescence during the whole pregnancy. It will keep the cervix integrity by preventing early cervix ripening and blocking the production of corticotrophin-releasing hormones and inflammatory prostaglandin, which are important for the onset of labor in the late pregnancy. Importance of the route of administration, as you can see, there are different pharmacodynamic and pharmacokinetic profile depending the route of administration. That was the thesis of the famous Professor Paul de Vrooij, an expert in luteal phase support. He was the head of the Brussels Fertility Center and the inventor of the ICSI methodology, when you can fertilize an egg with one sperm. And ICSI methodology is nowadays a standard of care, a worldwide procedure, and certainly when the male are involved in the subfertility. What he was demonstrating in his thesis is that if you administrate capsules of progesterone by the oral route, 100 milligrams twice a day, you can see that you have peaks and valleys. And that's not the case when you administrate the same dose by vaginal route of administration. And what was interesting in his publication, his thesis, was demonstrated that if you administrate 300 milligrams a day, you don't reach the magic cutoff level in the serum of 10 nanograms per ml. And you know, since the publication of Jane Jordan in the early 60s, that we consider a woman with a luteal phase defect when the mid-luteal progesterone serum levels are below 10 nanogram per ml. So that's based on this nice study that we did in oocyte donors, in women with premature ovarian insufficiency, meaning that we were measuring progesterone only based on the intervention of the capsules. You can see that you have very consistent and constant levels of progesterone into the blood when you administrate your progesterone by the vagina route, but 300 milligrams a day was not enough because you didn't reach really this magic cutoff level of 10. And that's the reason why nowadays, in all the centers around the world, we are using 600 milligrams of progesterone vaginally applied to be above this threshold of 10 nanogram per ml. Surprisingly, you can compare also the intramuscular route of administration, what is very common in the US, but you can see that if you use the intramuscular route of administration, you have 5 to 7 times more progesterone in blood. And that's probably the reason why in the US they prefer to use intramuscular injection, very high blood level. But you will see that the tissue level, the endometrial tissue level are very disappointing and even lower comparing to the vaginal route of administration. That's why worldwide in IVF, we are preferring to use vaginal progesterone because this high tissue concentration and with enough progesterone, more than enough, just above 10 nanogram, enough to compensate the luteal phase deficiency. You don't need to go to such a high supraphysiological level progesterone. But we know that it's tissue concentration which is crucial. And in this nice publication by Miles in Fertility Sterility 1994, you can see that by administering intramuscular progesterone, your levels in blood are quite very high. But when you look at the right side of the cartoon, the tissue level, you can see that you have higher progesterone tissue level by the administration of vaginal progesterone comparing to intramuscular progesterone. And the explanation for that is what we call the first uterine pass effect, because once you apply the capsules of progesterone into the vagina, it goes directly by passive diffusion into the cervix and into the uterus. And because there is this close relationship between vein and arteries into the uterus, progesterone comes back immediately by the artery, the ovarian artery, into the ovary and comes back into the uterus. That by the counter-current transfer of progesterone from the vagina to the vessels and to the ovarian artery, you have an optimal concentration of your progesterone into the vagina. And that's very important, but because that's the only way to have enough progesterone at the tissue level and to favor the implantation or to favor the pregnancy maintenance. So the route of administration is important, and Bruno de Linière in 95 was showing the difference in the area under the curve when you look at the progesterone blood level comparing oral or vaginal route of administration. And you can see that you have two major information from here. You can see that by administrating oral progesterone, the area under the curve is in terms of progesterone is about the same if you administrate oral or vaginal progesterone. You have slightly higher progesterone level by vaginal route, but what's the big difference is allopregnanolone. And you can see in the middle of the cartoon that allopregnanolone is increasing at a huge supraphysiological peak when you administrate progesterone by the oral route of administration. And you have not such a peak when you administrate progesterone by the vaginal route. And that gives the explanation why natural progesterone can induce some drowsiness or dizziness when the oral dose is too high. And that's what we need in IVF. And that's why we prefer to use vaginal progesterone instead of oral progesterone, even in IVF patients. But you will see later on that those side effects are modulated by the estradiol level in the background. So as long as you have more estradiol than progesterone, you compensate this allopregnanolone peak. So what's important when you look at the side effects of natural progesterone is to look at the estradiol levels. And if you increase the estradiol levels, you will not have any more those drowsiness and dizziness induced by the peak of allopregnanolone. But more easily, we prefer to use vaginal progesterone for IVF because you don't have this peak in allopregnanolone, and we can say that progesterone activities on the central nervous system will be modulated by the route of administration. And so, importance also of the formulation, because there are many vaginal progesterone preparation. What's important is to know how you produce your progesterone. So you imagine that we are not pressing ovaries to produce our natural progesterone. It's all about hemosynthesis from naturally precursor extracted plant extract like wild yam. But nowadays we are producing progesterone from soybean extraction. So they are natural plant source active ingredient. But what's important to have your progesterone bioavailable by oral or by vaginal route of administration is the micronization process in oil. And that's very, very important because it's through the micronization in oil and all the particles need to be less than 10 micrometers. And that can be only guaranteed by the drugs approved by the health authorities. And for example, dydrogesterone capsules are approved in more than 90 countries around the world for luteal phase support because all the particles in dydrogesterone are below this threshold of 10 micrometer, which is not the case for all the preparation. The oil excipient is also important, and the company who did dydrogesterone capsules selected sunflower oil because the dissolution of progesterone is optimal in this kind of sunflower oil without any allergenic reactions, such as with peanut oil or other oils. So the selection of the oil and the micronization are crucial. And unfortunately, all the copies, all the generic of this formulation, they were never able to demonstrate the bioequivalence because it's impossible to demonstrate bioequivalence based on progesterone blood levels when you look at the vaginal route of administration. I show you that what's crucial for vaginal route of administration is the tissue concentration. And there is no tissue correlation between tissue concentration and blood levels. So even if a formulation is demonstrating same blood levels of progesterone, it doesn't mean that the tissue concentration will be the same because this lack of micronization or the wrong selection of the oil. So the formulation to have an optimal tissue level concentration is very important. And with the dydrogesterone capsule, and that's why half of the IVF centers around the world are using the vaginal capsules and not other route of administration, is because you have a nice dose-dependent effect. And that's unique with the oil capsule formulation. You can see from 300 to 1,200 milligrams a day, you increase on a dose-dependent way the blood levels. But what's important to know for implantation, for pregnancy maintenant, is to be always above this magic cutoff level of 10 nanogram per ml. And you can see that at the steady state, your progesterone level will be above 10 if you are administrating at least 600 milligrams a day. The gold standard 20 years ago for luteal phase support was the crinone gel. And you can see when in this face-to-face comparison, the area under the curve with dydrogesterone capsules is about 15%, 50% higher comparing to the area under the curve with the crinone gel. That means the bioavailability of Dydrogesterone capsules is higher comparing to the bioavailability of the crino gel, vaginal gel preparation. What's important also, for example, in another face-to-face comparison, cyclogest pessary, which is not a micronization process in oil, it's a hard fat pessary. It's a suppository designed initially for rectal administration. You can see that the bioavailability of the cyclogest formulation is lower, 140 about the area under the curve, comparing to the area under the curve of the crino gel, which was the standard. So you can see that indirect comparison shows that the bioavailability of the formulation Dydrogesterone is superior to cyclogest, and that's the reason why you may see that in the guidelines, 600 milligrams Dydrogesterone capsules are more or less equivalent to 800 milligrams twice a day, 400 milligram cyclogest formulation. So both formulations are not the same. Another example to show you how important is the formulation, that's a clinical trial published by the group of Christina Berg in Denmark in 2012 in human reproduction. And you can see that the clinical pregnancy are statistically significantly lower with the crino gel comparing to the progesterone formulation in oil Dydrogesterone capsule. The ongoing pregnancy rate was borderline statistically significantly better with Dydrogesterone capsule. But at the end of the day, the equivalence of treatments in terms of ongoing intrauterine pregnancy rate could not be demonstrated because crino was not in the non-inferiority margin of -+7%. So you can see how important is the formulation even on clinical outcomes in IVF procedures. So let's now move to clinical efficacy results, because we are all clinicians and we want to know what's the importance of the clinical endpoints about what I was explaining, the differences in pharmacodynamics. So in other words, are all those pharmacodynamic differences clinically meaningful? And that's what I will show you in a couple of slides. So what about vaginal progesterone for luteal phase support in ART? Overall, when you look at the most updated Cochrane database, you can see that there is no difference in between several formulation preparation of vaginal progesterone. And I will explain to you why the Cochrane review was not able to make any difference in between progesterone formulation regarding the indication in IVF, because they didn't take into consideration the molecule, the route of administration, the formulation, and the cost effectiveness. And the reason why they didn't take into consideration is you can see that in this nice cartoon, you have a huge placebo effect. Don't believe that if you are not giving any luteal phase support in IVF, you will have no pregnancy. That's not true. You implement, you optimize your pregnancy rate, you increase your ongoing pregnancy rate, clinical pregnancy rate, live birth rate, statistically significantly. But if you are not giving any progesterone, you have some pregnancies. That means that if you want to demonstrate non-inferiority in between all those formulations, you need to randomize at least 2,000 patients in non-inferiority study. And that was never done. And it will never be done anymore because it's ethically not acceptable to give anymore a placebo in a woman in an IVF cycle, because you know how complicated it is to get a pregnancy in subfertile women. So it will be not acceptable anymore to give those women a placebo just to make a differentiation in between formulation. So all the studies that are included in the Cochrane review are very old studies at the time that we were not sure that you need progesterone supplementations for luteal phase support. But nowadays, it's a gold standard. So we don't need to know if progesterone works. It works, but it's very, very challenging to show the difference in between formulations. So how to do? We were looking at the similarities, the differences, and certainly a new trend is that in the personalized medicine world, we want to individualize, to optimize on individual patient the luteal phase support with vaginal progesterone. So what are the clinical trials available to make a difference between vaginal progesterone and oral dydrogesterone? You all know the results of the two big trials, non-inferiority studies in between Dufaston, dydrogesterone, and the capsules of Dydrogestan, vaginal progesterone, micronized in oil, or the comparison of dydrogesterone with the crino gel. So those studies were suggesting non-inferiority versus vaginal micronized progesterone, at least in fresh cycle. They never did any comparative study in fed cycle. So first information, you need more information with dydrogesterone in fed cycle because there is no data. The only data that we have, let's say with a well-designed comparative study, is in fresh cycle. But when you look at the abstracts of those two pivotal studies, comparative study, first, they were not done in fed cycle, and all those studies were not powered to demonstrate non-inferiority on the live birth rate. And we all know that the gold standard nowadays to compare the efficacy of luteal phase support in several formulations is to use the live birth rate as an endpoint. So if you look at publication, be careful, you need enough patients for the comparative study, at least 2,000. You need the live birth rate as an endpoint. And we are doing more and more fed cycles. So that's all information missing with synthetic dydrogesterone. So in terms of efficacy, we can say that Dufaston has some similarities with vaginal progesterone, but we miss some crucial information in fed cycle on the clinical live birth rate and in the optimal dosing for individualization. What about safety? When you look at the safety, the best guidelines we have endorsed by the Guideline Development Group Committee at ESHRE is the comparison between vaginal progesterone. The ESHRE committee gives a strong recommendation versus dydrogesterone, who has only a conditional recommendation. And why they have only a conditional recommendation? Because there are safety issues with synthetic progestogens overall, more especially with dydrogesterone, about congenital heart disease in the neonates. So there are some questions raised by Zakut in the Lancet 2017, in Pediatric Cardiology 2020. But more importantly, and that's very recent, two big publications based on pharmacovigilance surveillance program. One in France by Aung, presented at the ESHRE meeting last year, and another by Li in China, are raising the question about the safety of synthetic dydrogesterone on the fetus, on the abnormalities in the birth neonates. We also know that in clinical trials, there are some problems of fetal anomalies detected in IVF patients, or even effects on spermatogenesis, or even a very strange case of delayed fulminant hepatic failure in a woman in Thailand who took dydrogesterone and who has to abort because a need for transplantation due to this hepatic failure. So you have some concern in terms of safety, and that's the reason why the ESHRE is waiting for more safety data before making a strong recommendation for dydrogesterone. But more importantly, based on Labarta studies very recently, we want to individualize our luteal phase supplementation. And what Labarta is suggesting is to measure progesterone in blood, to monitor and to see the woman has enough progesterone for optimizing the pregnancy and to decrease the miscarriage rate. Unfortunately, you cannot monitor progesterone level by administering synthetic progesterogens, because synthetic progesterone, such as dydrogesterone, do not increase the progesterone blood levels. So you cannot monitor your progesterone blood level by administering synthetic progesterogens, and that's the gold standard now in FET cycles. And why it's a gold standard in FET cycle? Because we know that some poor responders with vaginal progesterone need to increase the dose of progesterone based on insufficient progesterone blood level. And that's what we can do. We can rescue those patients by adding some progesterone comparing to the standard of care dose. And there are many publications on that in the last 2 or 3 years. So we can say that there is a place for individualizing our luteal phase support at the condition that you can monitor the patient by measuring progesterone in blood. Are all the pharmacodynamics differences that I was mentioning to you clinically meaningful versus dydrogesterone or synthetic progestin? I show you this huge effect of progesterone as a tranquilizing hormone, and that will decrease the stress in pregnancy, and that's unique for progesterone. You don't have with synthetic. You have the diuretic effect to compensate the hyperestrogenemia induced by control ovarian stimulated cycle. You have this tocolytic effect, which is important to block the contraction during the implantation process, but also to decrease the contraction before the onset of labor. And you have the neuroprotective effect, which is very important, not because it's produced in mother's brain, but also because it will decrease the brain injury and the risk of ischemia and hypoxia, more especially in preterm neonates. So you can see you have 4 crucial differences, clinically meaningful differences in between natural progesterone and synthetic progestin. And probably the earliest important difference is the fact that natural progesterone is not only enable decidualization of the endometrium, and it will inhibit the myometrium concentration. And the group of Bulletti in 2022 was demonstrating, for example, that you can prevent ectopic pregnancies by decreasing the incontraction during the implantation process. So uterine relaxation before the embryo transfer is likely to improve IVF embryo transfer outcomes by avoiding the displacement of the embryo from the uterus cavity. So you can see how this membrane effect in a few seconds can prevent some important clinical outcomes. That's a summary by Labarta about the optimal dosing of vaginal progesterone, not only in FET cycle, but also in natural cycle, which is a more controversial discussion. But even if we place a frozen torn embryo in a FET cycle, you need to supplement with extravenous progesterone in order to decrease the miscarriage rate and to optimize your pregnancy. Probably the best way to convince you that the first intention treatment for luteal phase support around the world is a survey published by Shoam in 2021, and using what all our colleagues around the world are using for luteal phase support in IVF. And you can see, for example, that over 270 IVF units, more than 80 countries, based on more than 250,000 annual cycles, all centers, 77% of the cycles are using vaginal progesterone only for luteal phase support. Lesser than 5% are using dydrogesterone. And as I mentioned, in the US, you have a little bit more cycles, but only in the US, where they use intramuscular or subcutaneous progesterone. But also some centers, they prefer to use both, a combination of, in any case, vaginal progesterone with other drugs. So that's what all our centers around the world are doing. And when we look at the evidence, I show you the results of this Christina Berg study, and you can see that on clinical pregnancy, ongoing pregnancy, positive ACG pregnancy, all those clinical outcomes are better with your progesterone capsules comparing to the crinoline gel for luteal phase support in fresh cycle. What's also very interesting, a very recent study published and presented at the ESHRE Congress 2023 is to see that before sending a woman to an IVF center, you can suggest progesterone, for example, 2 times 200 milligrams twice a day, and you can restore women with unexplained fertility. So that was a study based on 143 couples with unexplained fertility. That was called the PINK trial. And during 3 menstrual cycles, they were giving 400 milligrams twice a day for 14 days. And you were restoring live birth rate, biochemical pregnancy, clinical pregnancy rate better than with the placebo, and a decrease in the miscarriage rate if you were randomizing patient with those 3 menstrual cycles with natural progesterone before implantation, so during the luteal phase, to treat unexplained pregnancy. What about the clinical experience with the oil capsule? And you can see consistently, independently of the country where the publication, the randomized control trial was done, in fresh cycle, we have about 18 trials in more than 4,600 patients in fresh cycle. Consistently, they were using or 600 or 800 milligrams a day vaginal progesterone capsule. And you can see consistently an optimal clinical pregnancy rate and an ongoing pregnancy rate in all those studies. We started the program at Brussels University in 1992 in the department of Professor Paul de Vroey, and Johan Smith was showing that 600 milligram vaginal progesterone, at the time we were suggesting even with estradiol, was improving our clinical and ongoing pregnancy rate comparing to intramuscular route of administration, which was a gold standard at the time. But since 1992, there were a lot of studies, not only in fresh cycle, but more recently in fed cycle, where we have more than 4,475 patients, also in randomized control trial in all over the world. And the last one, published in The Lancet by Aung and Ho, is a very important study showing how works dydrogesterone oil capsules for luteal phase support when you administrate 2 times 200 in the morning and 2 times 200 at bedtime for the luteal phase support in fed cycle. That's the most recent study, but you can see that since more than 20 years, we have a huge experience around the world on the efficacy based on clinical endpoints of vaginal progesterone. Why the ESHRE are clearly recommending and make a strong recommendation, as you can see, for the 200 milligram 3 times daily of micronized progesterone capsule. But you can see also that for dydrogesterone, there is only a conditional recommendation. And the reason is that you cannot monitor your patients with giving dydrogesterone. Why? Because when you give vaginal progesterone, you have a uterine path effect, as I mentioned in my introduction, and you have a physiological diffusion of your progesterone, ensuring a progesterone blood level at the steady state about 12 nanograms per ml. But if you administrate dydrogesterone oral pill, which seems to be more convenient for the patient, but that was never shown in any randomized control trial. But even if you suggest to administrate synthetic dydrogesterone, you will need an intensive hepatic first pass metabolism to activate difastone in the active hormone, which is a 20-alpha dihydrodydrogesterone, DHD. And you cannot measure this metabolite in blood because you need a highly specific and costly chromatographic effect. So it's not possible to improve the patient outcomes by monitoring the blood levels because you cannot measure those metabolites in blood. And as it was shown a long time ago by the group of Balash, you can see that there is here no difference in progesterone blood level if you administer during the luteal phase Dufaston versus women without any luteal phase support. So Dufaston doesn't modify the profile of the progesterone blood level, the reason why you cannot monitor the patient in fed cycle. And it's important to monitor our patients because that's the study published by Neumann in Human Reproduction 2022. And you can see that in about 25% of the patients, they got not enough dydrogesterone blood levels or dydrogesterone, the active metabolites blood level. And the ongoing pregnancy rate was 1/3 of the optimal classical pregnancy rate that you have if in case you have enough hormone in your blood circulation. You can see, so it's so important to be sure that you give enough dydrogesterone to your patient, but you cannot monitor your patient. You cannot see if the patient has enough dydrogesterone to supplement, which is not the case with the natural progesterone, because in natural progesterone, you measure progesterone, and if progesterone levels are below 10 nanogram per ml, you increase the dose or you change the route of administration. So the ongoing pregnancy rate was significantly reduced in 25% of the patients versus 28% in the lower quarter of dydrogesterone or dydrogesterone level. That means that probably if you give the standard dose of dydrogesterone to your patient in fed cycle, you will miss an optimal clinical pregnancy rate in one patient in 4, which is quite significant. What about safety? And I was showing how safety is important once it goes about intervention during pregnancy. You can see here, I summarize all the randomized control trial in IVF, more than 9,000 patients, in threatened and recurrent miscarriage or in preterm delivery. So you can see that we have nowadays more than 18,000 patients in placebo randomized control trial showing the safety on the neonates, healthy infants with vaginal progesterone, so we can speak about a level 1 of evidence in terms of safety. Is it the same with synthetic progestogens, like oral dydrogesterone, for example? And that the study that I was mentioning in pediatric cardiology and in the Lancet, and the findings were suggesting that the exposure to dydrogesterone during the first trimester of pregnancy was more frequent among mothers of children born with congenital heart disease. There were about 2.7 statistically significant more congenital heart diseases in this observational study done in the band de Gaza, where all pregnant women are offering dydrogesterone for pregnancy maintenance. But more importantly, based on this band de Gaza study, there was a huge pharmacovigilance surveillance program at the European level. And you will see that last week, or 2nd of January 2025, a huge publication in Human Reproduction Open was suggesting the birth defects, reporting and the use of dydrogesterone, a disproportionality analysis from the World Health Organization based on this huge pharmacovigilance program. And what this program is showing, that you have about 5.4 times more birth defects with dydrogesterone comparing to vaginal progesterone users. And that's also true versus users of other drugs in IVF. So 3.6 times more birth defect cases dydrogesterone versus progesterone in head-to-head comparison. And 44 out of 60 cases of dydrogesterone reported at least one major birth defect. So it's a huge safety concern that was raised by this group of Cochin Hospital in Paris, which analyzed all the pharmacovigilance European surveillance program. But that's not only in Paris and in France, but they got exactly the same results in China. and that the pharmacovigilance program recently published by Lee 2024, end of last year, showing that there was an overall incidence of adverse pregnancy outcomes of 13%. That means that more than 1 patient in 10 pregnant patients exposed to drugs in China, they will face adverse pregnancy outcomes. And when we are looking at the pregnancy outcomes comparing dydrogesterone and progesterone on miscarriage, abortion, stillbirth, preterm birth, low birth weight, birth defect, you can see that birth defect, low birth weight, and preterm birth are all significantly increased in the dydrogesterone group, but not in the natural progesterone group. And we can see only an effect on prevention of miscarriage with oral dydrogesterone, but probably it was significantly decreased versus natural progesterone because in China, we are not using vaginal progesterone. They use vaginal reproduction. But even if you have a slight efficacy effect on miscarriage, at least in this Chinese surveillance program, you have an unacceptable increase in stillbirth, preterm birth, low birth weight, and birth defect in the dydrogesterone groups. And so we have to consider this in the guidelines. And when you look nowadays at the Royal College guidelines in the UK, based on what I was saying, it's clearly mentioned that in relation with dydrogesterone, caution should be exercised when interpreting the results of the meta-analysis, where they were showing that dydrogesterone has, or different randomized control trial, including the Kumar study, was showing that dydrogesterone works for threatened miscarriage. And I will show you that the major paper showing that dydrogesterone works on prevention of threatened miscarriage, the Kumar paper 2014, was very recently retracted, what was mentioned by the Royal College guidelines. But anyway, progesterone supplementation should be considered in women with a recurrent miscarriage who present with bleeding in the early pregnancy, and they suggest 200 milligrams 2 times twice a day from bleeding until 16 weeks of gestation. So that the grade B recommendation by the Royal College to treat women with unexplained recurrent miscarriage. So when you look at recurrent miscarriage, we have a lot of evidence now showing how works progesterone based on the PROMISE trial, the PRISM study, a Cochrane review, and also a negative study with synthetic dydrogesterone by Sham in Human Reproduction 2020. And you have a lot of recent studies with a level of 1 of evidence showing how works progesterone for the prevention of preterm birth, the EPIC meta-analysis, which is an individual patient data meta-analysis that was published in the Lancet, but with all the studies by Roberto Romero in the American Journal of Obstetrical and Gynaecology, and a nice paper by Aung in the British Medical Journal. So you can see that worldwide, vaginal progesterone now is considered as a standard of care for the prevention of preterm birth. What about the optimal concentration for the daily dose? Be careful and looking at the different formulations, but if you want of cyclogest is lower. Prevention of threatened miscarriage is a huge problem, and it is very crucial because miscarriage, and certainly recurrent miscarriage, will induce a lot of emotionally frustrating problems for couples. Even 1 woman in 5 will have a post-traumatic stress disorder-like symptom. They are fully depressed, and 20% of women has bleeding before 12 weeks of gestation. And unfortunately, most of those women will have a miscarriage. Only 1 in 3, but 1 in 3 of 20% of pregnancy is a huge number of women with a threatened miscarriage, 1 in 6 pregnancy overall. And that's important because it will induce a lot of problems in terms of risk of prematurity, placenta abruption, or 1.6 times more likely all those pregnancy will end in a stillbirth when it goes about recurrent miscarriage. And the rationale to understand why progesterone works in threatened or recurrent miscarriage was developed by a very famous gynecologist in the 70s, Arapat Chapo, and he was showing very nicely, for example, that if a woman wants to go for abortion and you do a tubal ligation, you can see that progesterone blood level after the tubal ligation, which is a normal procedure for abortion, progesterone blood level doesn't decrease, and you need to do a dilatation curettage. But if you remove the corpus luteum, the production of progesterone into the ovaries before 7 weeks of gestation, all those women went for a direct miscarriage without doing a dilatation curettage. But what's interesting, when they was rescuing those women where they remove the corpus luteum before the 8 weeks of gestation, but they were giving progesterone, there was no decrease in progesterone blood level, and no one had a miscarriage. So this guy demonstrated how important it is to give exogenous progesterone to maintain high level of progesterone to prevent an early miscarriage. So we have the biological plausibility to explain how works progesterone in the prevention of threatened miscarriage. And that's a huge cohort study. In blue, that's the normal progesterone levels in normal pregnancy, but who lower are the progesterone levels, who higher is the risk for threatened miscarriage. And here the threatened miscarriage risk group here on the right side, you can see that if for those women who really had a miscarriage, progesterone levels were even lower. So we know also that an unsuccessful, inadequately regulated sequence during the luteal phase can induce preeclampsia risk. You know all the process of implantation based on apposition, adhesion, invasion, and decidualization. And you have something wrong going during the trophoblast invasion, and that can be induced by luteal phase defect, not enough progesterone in the early implantation process. You will have a problem of risk of preeclampsia. And what we did, we compare face-to-face utrogestan to dydrogesterone, and you can see that only utrogestan is able to decrease the pulsatility index of the arterial vascular system. And that means that, again, based on this biomarker that Kypros Nicolaides is using to identify the woman at risk for preeclampsia, only one progesterone formulation is able to act on the artery pulsatory index and not the synthetic dydrogesterone. So vaginal progesterone treatment was associated with a decrease in the spiral artery pulsatory index in this publication in Fertility Severity 2007. So again, a reason to believe that both progestogens are not equally efficacious, at least, for example, to prevent miscarriage, but certainly to prevent a preeclampsia. And as Mary Stephenson in Fertility Sterility was showing, you have to initiate your luteal phase support as soon as possible. And that was nicely demonstrated in this woman with a high risk of recurrent pregnancy loss, because the women were carrier of a biomarker, a risk factor for recurrent miscarriage. And why is progesterone working nicely in miscarriage? Because we know nowadays that who more you have previous miscarriage in the history, who more progesterone will be able to prevent another miscarriage, because the rate of miscarriage induced by abnormal fetal karyotype progesterone will not prevent a threat. prevention of threatened miscarriage with progesterone doesn't work if in a new first pregnancy. But if the woman has at least one or more miscarriage in the history, who better progesterone works. And you can see that the more you have miscarriage in the history, who higher is the risk for a subsequent miscarriage. By each miscarriage that you add in the history of miscarriage, you increase by 10% the risk of miscarriage. So who more miscarriage in the history, who better progesterone works, but who higher is the risk of another miscarriage if you don't take progesterone. And that's why, based on the PRISM study, the guidelines were recommending the use of vaginal progesterone if you have at least one miscarriage in the history. You can see that you increase the live birth rate statistically significantly by 9% by administering progesterone. And that was confirmed in this meta-analysis by the group of Komarazami from Birmingham in the American Journal. You can see that consistently for threatened miscarriage or for recurrent miscarriage, you decrease significantly the risk of, you increase the live birth rate in women receiving progesterone in all those studies based on this meta-analysis. Are all progesterone even efficacious for the prevention of threatened miscarriage? That's a double-blind, placebo-controlled study published in Human Neuroprotection, and you can see that the use of oral progesterone was not statistically efficacious, different from the placebo, in preventing miscarriage or in improving the live birth rate. And that was fully endorsed by a Cochrane review, when you can see that based on the Cochrane review and one well-designed study for the prevention of threatened miscarriage, there was no difference between the placebo and the dydrogesterone. And the reason why it was not statistically significant is because the pivotal study that everybody is using around the world by using dydrogesterone for the prevention of recurrent pregnancy, the Kumar study published in Fertility 2014 was retracted very recently last year, because the committee of the journal was asking the authors to acknowledge the significant errors that could not be corrected because they were unable to provide original data. So there was no evidence anymore to recommend dydrogesterone for the prevention of recurrent pregnancy. What about the efficacy with vaginal progesterone? You can see that here we increased, based on the last Cochrane review, the live birth rate by 8%. And that's the reason why it's fully endorsed, not only by the recent guideline, by the ESHRE or by the NIS. And if you look at the NIS guidelines, they are recommending 200 milligram 2 times in the morning and 200 milligram 2 times at bedtime. And that's only micronized vaginal progesterone that will be able to increase the number of live births in women with early pregnancy bleeding and at least one previous miscarriage. What's important to know in the NIS recommendation that there was no evidence of benefits for any other preparation or other doses of progesterone. So 800 milligrams a day important from bleeding diagnosis until 16 weeks of gestation. I will conclude my presentation by all the evidence we have for the prevention of preterm birth. We know that preterm birth is a huge problem, and certainly in your country also, about 10% of women will face a preterm delivery. And the two major more strength factors for the risk of preterm birth is a shortening of the cervix at mid-gestation measured by ultrasound or a history of a previous preterm birth. But you can see that if vaginal progesterone is able to decrease the risk in those women, you will address only part of the preterm delivery. So one treatment doesn't fit all. But we have now plenty of evidence, about 20 randomized control trials, most with vaginal progesterone capsule, showing how works progesterone for the prevention of preterm birth. And that was nicely summarized in this meta-analysis in the Lancet by the EP group, evaluating the progestogenes for the prevention of preterm birth. And you can see all high-quality studies And I summarized in this cartoon from the supplementary table of the Lancet all the study done with vaginal progesterone capsule. And you can see that you have a decrease of 21% of preterm delivery if you administer 200 milligram capsules of progesterone from mid-gestation when you measure the cervix, or for week 16 of gestation if there is a history of a preterm birth, until week 36 of gestation. Nicely demonstrate decrease in the preterm birth rate before 34 weeks, statistically significant, which was not the case with injections. And you can see that you improve all the neonatal outcomes like birth weight, the admission in the neonatal intensive care units, the respiratory distress syndrome, and all are statistically significantly improved by the administration of vaginal progesterone to the mother. And that's why there was a new strategy put in place by the very potent US Society for Fetal Maternal Medicine, led by Vincenzo Berghella, and he published recently in the American Journal that the prophylactic vaginal progesterone starting at week 16 days every night should be offered to singleton with prior singleton spontaneous preterm birth, regardless of the cervical length, and continued along with placement of cerclage if a transvernal ultrasound cervical length less than 125 is detected at weeks 24. So you can see that there is no reason to believe that cerclage works better than vaginal progesterone in women with a history of preterm birth, and certainly not in women with a shortening of the cervix. And that was nicely demonstrated by this network meta-analysis by Aung in the British Medical Journal 2022, when they conclude that vaginal progesterone should be considered the preventative treatment of choice for women with singleton pregnancy identified to be at risk of a spontaneous preterm birth because a history of spontaneous preterm birth or a short cervical length measured at mid-gestation. And that's the indirect comparison in between cerclage and progesterone, showing that we have exactly the same effect. There is no superiority of the cerclage comparing to vaginal progesterone. So the take-home message from my presentation will be that the role of progesterone in the physiopathology of pregnant women is crucial from conception until delivery. There is a strong biological plausibility, pharmacodynamics, and high-quality, meaningful level of evidence to support the exogenous vaginal progesterone formulation for the management of pregnancy maintenance from conception until delivery, including the prevention of preterm delivery in women at risk, and neonatal effects, safety, health infant, and cost effectiveness with vaginal micronized progesterone capsule are available with a level 1 of evidence based on all the randomized control trial that I was showing to us. So I thank you for your attention, and I'm very happy to answer all your questions.
Thank you very much, Mr. Paul Piet. It is a brilliant presentation, and we have shared your experience. And there will be some queries coming up from the chat box.
Okay.
I never thought, huh? The first one is, after early pregnancy progesterone support, do we need progesterone in the third trimester?
That's a good question. When you listen to the recommendation of Giancarlo Di Renzo, the General Secretary of the FIGO, which is also, by the way, a progesterone expert, everybody knows around the world Giancarlo Di Renzo, he made a hypothesis that, in fact, all the etiologies of compromised pregnancies are sometimes with some common causes. And for sure, we cannot compare the risk factors for threatened miscarriage, preterm delivery, or for optimizing implantation. But there are some common etiopathologic pathways. So once we know that progesterone works, for example, to optimize implantation, and that you are delivering 800 milligrams a day progesterone vaginally applied for implantation and until week 12 of gestation, in fed cycle, for example, even if we are not sure that you have to continue the treatment, there are some experts who prefer to keep the treatment until week 20 in order to prevent a threatened or recurrent miscarriage, and then to decrease the dose to 200 milligrams instead of 800 milligrams from week 20, once you have no risk of early or threatened miscarriage anymore, but to prevent the risk of preterm birth. Because you have to know, for example, that you have 3 times more preterm births in women from IVF, conceived from IVF. And you have about 2.5 times more miscarriages, in late miscarriages, in the woman from IVF pregnancies. So there is some common pathway about the efficacy of vaginal progesterone to maintain and to optimize your pregnancy. So to answer your question, yes, you can downgrade the concentration of progesterone from, let's say, mid-gestation, and at least to give 200 milligrams from week 16 or 20 until week 36 to maintain enough progesterone to protect the cervix. But that's an expert opinion. It's not based on the evidence or randomized control trial.
The second question, I think you have already answered the second question, because she wanted to know what is the time to start treatment for the threatened miscarriage and when to stop. So if wanted to
absolutely. Ideally, for sure, you never know if the woman will have a threatened miscarriage or not. You have some risk factors, for sure. If you have a woman with more than 1 miscarriage in the history, I should start your luteal phase support as soon as possible. That means that once you know that there is risk of to be pregnant, you have to start immediately, or earlier or better progesterone works, because progesterone works as a preventative intervention. Once you have an acute problem, it's too late. So my recommendation, and based on the Mary Stephenson study, who earlier you start your progesterone, who better it works. And for threatened miscarriage, the problem if there is no bleeding, you have no risk factors. If the woman is in the first pregnancy, you don't know if she's at risk for threatened miscarriage. And we know that in the first pregnancy, more than 50% of abortion or miscarriage are induced by karyotype malformation, and then progesterone doesn't work. But so as early as possible is the answer.
Another question is whether there is particular contraindication for the first trimester treatment.
With that, sorry, I didn't capture the question. What?
Any particular contraindication for the first trimester's treatment?
But theoretically, there is no very absolute contraindication for giving progesterone. The only you can have some allergenic reaction to any ingredient of the formulation. So sometimes you have to be careful with allergenic reaction, but they are very rare, and they are more common with injection, because in the injection you have the oil, which can induce a lot of allergenic reaction, even pneumonia, eosinophilic pneumonia, and so on. So there are no real absolute contraindication for, at least as long as you give vaginal progesterone or natural progesterone, because progesterone is the hormone of pregnancy. But you have to rely to the patient leaflet, and there are some contraindication in the product information leaflet that you can find very easily, but they are not so common.
All right. Another one is, what are the different indications for the use of oral dydrogesterone?
So I think that oral dydrogesterone has shown to be very efficacious to regulate bleeding. I should not use, based on my presentation at least, I should not use synthetic dydrogesterone anymore in pregnancy because you have this concern about the safety and certainly about the birth defect and the cardiac malformation of the neonates, as long as we don't have a clear long-term randomized control trial showing the safety. And the huge experience that you have probably in Myanmar and in all your countries, dydrogesterone, is only based on treatment of threatened miscarriage when you initiate dydrogesterone from week 6 or 7 of gestation. But when you start at week 6, most of the miscarriage occur beforehand. And it's not because you are safe by starting dydrogesterone at week 6 that you are safe by giving dydrogesterone before implantation to favor implantation. So we need more safety data before recommending dydrogesterone. So I should keep dydrogesterone, which is an excellent progestogen, to regulate the cycles and to have ovulatory cycles and to compensate the luteal phase defect in women with irregular cycle.
All right. Any recorded reports for the congenital anomalies while in the first trimester use of progesterone?
But the only data we have are coming from those 2 pharmacovigilance surveillance programs, and at least in China, you know, they use extensively progesterone or dydrogesterone in pregnancy. And based on this huge Chinese pharmacovigilance database, there is absolutely no increase in any risk of congenital malformation or any adverse event by giving natural progesterone, which was not the case of dydrogesterone. And in Europe, this VG-based database, which is a huge pharmacovigilance database, was showing exactly the same, that you have 5 times more adverse events and birth defect in women taking dydrogesterone versus natural progesterone. So there are 2 independent safety surveillance programs showing the same signal. So I should be very cautious. And there is no one study showing that in IVF, at least, patients are more compliant by using oral dydrogesterone versus vaginal. In the 2 Lotus 1 and Lotus 2 studies, it was clearly mentioned in the discussion of the paper that when we were looking at the patient compliance, it was exactly the same in the patients taking oral tablet versus vaginal. And that's not surprising because they're highly motivated patients and they want to have a baby, and they will be very happy even to put some progesterone capsule in the vagina. The only problem is sometimes you have some bleeding. You know, a lot of women has bleeding during the IVF procedure because of the procedure, and some women doesn't like to put something in the vagina if there is some bleeding. But what you have to keep in mind is that the bleeding will stop immediately after 1 or 2 days of vaginal progesterone intake if the bleeding is induced by a luteal phase defect. For sure, if there are other causes for the bleeding, you have to investigate. But bleeding is not a problem even for the vaginal introduction of progesterone because it stops immediately once you introduce the progesterone treatment.
And another one is, what is your opinion on the routine use of progesterone in the pregnancy, early pregnancy?
That you need to identify clear risk factors because Mother Nature is well done. So in most of the pregnancy, you don't need any additional progesterone. But if you have any risk, and for example, any IVF procedure, when you disrupt completely the feedbacks in the hormonal environment of the ovaries, so in fat or fresh cycle, it was clearly demonstrated that you need exogenous progesterone. Even in fat cycle, when you replace a frozen torn embryo in a natural cycle, it's clearly demonstrated that you need an additional progesterone. Why? Because about 1 woman in 10 with normal cycles, she will have luteal phase defect. she will not reach the 10 nanogram per ml threshold of progesterone in the mid-luteal phase. And that can compromise her pregnancy and certainly the early pregnancy, and that can increase the risk of miscarriage. So you need an additional exogenous progesterone even in those women when you replace the frozen tone embryo in the natural cycle. And for sure in artificial cycle, you need to fully supplement the luteal phase by eutrodestat or by a progesterone, and that's why you need higher doses. You need probably 800 milligrams, and even in about 10 to 15%, you need to increase the dose. Some are poor responders, or if the vaginal absorption is not optimal, you need to give, and then my recommendation is to give an oral progesterone, an additional 300 milligram oral progesterone intake to compensate the lack of penetration of progesterone through the vagina.
Another question is what to do if there's any side effects?
That's a good question. So there are the two major side effects are all dizziness, drowsiness, but they are more related to oral intake because it's related to the production of allopregnanolone. And so in this case, I think that you have to move from another route of administration, for example, to take the progesterone by the vaginal route of administration instead of the oral route of administration. Drowsiness and dizziness is not a problem with the vaginal route because you don't have this increase in allopregnanolone, so you never have any drowsiness or dizziness with the vaginal route of administration. And if there is too much bleeding, you can offer the capsule or pessary by rectal route of administration, the time to decrease the bleeding for a couple of days, and then to move back to the vagina. We don't like the rectal administration for compliance reasons, and also because the variability of the penetration of progesterone through the rectal mucus is quite highly variable comparing to the vaginal mucus, which is a smaller surface. So the inter-individual variability is lesser when you put the progesterone into the vagina instead of the rectal administration. But also for patient convenience, for sure.
All right. I think Dr. Aung's third question is already answered, that you can change from one progesterone to the another. Cherry-san question is, can we give natural progesterone to a woman with family history of DVT?
That's a very good question. The only experience we have is in another model, which is the postmenopausal woman. And there are two studies, one published in Circulation, based on a French study called the E3N study, and another study published in ATVB journal based on the ESTER study. There are two case control studies done in France, suggesting that when you give natural progesterone, you have any increase in VTE risk in postmenopausal women. Postmenopausal women is an interesting model because they don't produce anymore any estradiol or progesterone, so you can evaluate exactly what the side effects of the drugs that you are administrating, and by giving for even 5 years time in the ESTER study and the E3N study, they were not observing any risk of VTE in those patients taking vaginal oral progesterone. So theoretically, the increase in VTE risk is related to some synthetic progestins that are in any case contraindicated in pregnancy, such as noritestosterone acetate, medroxyprogesterone acetate, or the synthetic progestogens.
Thank you very much. There's no more questions. Thank you very much for your brilliant presentation and also your excellent answer for our queries. Mr. Paul Piet, I am very grateful for your talk today, and hope we will be meeting you again in this field of progesterone and the pregnancy complication. I would like to hand over the program to the Master of Ceremony. Thank you very much.
Thank you, Professor Aung, for your kind invitation, and happy to meet you as soon as we can in the international meeting.
Thank you, Dr. Paul, for this needful information, and also thank you, Basiai. According to Agenda 5, may I kindly invite PR and Product Manager Dr. Aung for the product presentation of Dydrogesterone.
Thank you, Rajan.
Aung မင်္ဂလာပါခင်ဗျာကျွန်တော်တို့ medical products မှာ product manager ဒေါက်တာအောင်ကြီးလိုင်ဖြစ်ပါတယ်ဒီနေ့ကျွန်တော်ရဲ့ talk လေးကတော့ဒီ Dydrogesterone နဲ့ပတ်သက်တဲ့ product presentation လေးပါခင်ဗျာDydrogesterone ကတော့100 mg နဲ့200 mg နှစ်မျိုးလာပါတယ်ခင်ဗျာ100 mg ကတော့လုံး30ပါပါတယ်200 mg ကတော့15လုံးပါတယ်ပူလေးပါခင်ဗျာခုနဒေါက်တာပေါ်အမိရှိသွားသလိုပဲကျွန်တော်တို့ဒီ Dydrogesterone မှာပါဝင်တာကတော့ natural micronized progesterone ဖြစ်ပါတယ်အဲ့တော့ body ထဲကကျွန်တော်တို့ရဲ့တဘာဝပေါ့နော်တဘာဝဟော်မုန်းဖြစ်တဲ့ progesterone နဲ့ထပ်တူထပ်မျှတူအောင်လို့ထုတ်ထားတာဖြစ်ပါတယ်ဒါကြောင့်မလို့side effect ပေါ့နော် virus ဆိုကြိုတွေ intent နေပါတယ်နောက်အထူးသဖြင့် pregnancy မှာသုံးရတဲ့အတွက်အလွန်အရေးကြီးပါတယ်ခုနဆရာကြီးလည်းမေးသွားသလိုပဲဒီဆရာကြီးဒေါက်တာပေါ်လည်းဖြေသွားသလိုပဲကျွန်တော်တို့ဒီnatural progesterone ဖြစ်တဲ့အတွက် throughout the pregnancy မှာသူ့ကိုစိတ်ချလက်ချပေးလို့ရပါတယ်ခင်ဗျာပါဝင်တဲ့ပစ္စည်းကတော့ natural micronized progesterone 100 mg 200 mg ဖြစ်ပါတယ် indication အနေနဲ့ကတော့ခုနပြောသွားသလိုပဲအများကြီးရှိပါတယ်သို့တော့ main indication ကတော့အဓိက prevention of the preterm birth ဖြစ်ပါတယ်အဲ့ဒီမှာ premature labor acute phase ကို premature labor maintenance phase မှာပဲသုံးလို့ရပါတယ်အဲ့တော့ prevention of preterm birth ဆိုရင်တော့ပုံမှန်ဆို200 mg OD per vagina သုံးလို့ရပါတယ် acute phase မှာဆိုရင်တော့400 mg per oral 6 hourly ပေးလို့ပြီးတော့from 20 to 36 weeks of pregnancy and followed by maintenance phase 200 mg TID per oral until 36 weeks of pregnancy ဖြစ်ပါတယ်Dydrogesterone ရဲ့ထူးခြားချက်လေးကတော့သူက oral နဲ့မကဘူးပေါ့နော် vaginal route ပါပေးသုံးလို့ရပါတယ်အဲ့ vaginal route သုံးတဲ့အကျိုးကျေးဇူးကတော့ first uterine pass effect ဖြစ်တဲ့အတွက် targeted delivery ဖြစ်ပြီးတော့သူကဘေးထွက်ဆိုးကျိုး impact နည်းပါတယ်အရှင်လည်းပို့ပြီးတော့မြန်ပါတယ်ခင်ဗျDydrogesterone ရဲ့နောက်ပြောတဲ့ဒီ oral အပြင်ပေါ့နော် vaginal use လည်းသုံးလို့ရတဲ့အတွက် additional effects တွေနဲ့ oral use သုံးရင်တော့ CNS effect လေးတွေအနည်းငယ်ရှိပါတယ်အဲ့ဒီမှာခုနဆရာဒေါက်တာပေါ်ပြောသွားသလို luteal phase deficiency မှာပေးလို့ရတယ်နောက် irregular bleeding ရဲ့ secondary amenorrhea တွေမှာလည်းသုံးလို့ရပါတယ်နောက်တစ်ခုက post menopausal women တွေမှာcombination with estrogen နဲ့တွဲပေးလို့ရပါတယ်နောက် stress during pregnancy အပြင်ကို women with anxiety in premenstrual syndrome တွေမှာလည်းပေးလို့ရပါတယ် vaginal route ကတော့ CNS effect လုံးဝမရှိပါဘူးဒါပေမဲ့သူ့ကိုကြတော့အဓိကတော့ luteal phase support အနေနဲ့ပေးလို့ရတယ် especially ဒီ infertility conception case တွေနဲ့နောက် prevention of preterm delivery တွေမှာသုံးလို့ရပါတယ်side effect အနေနဲ့ခုနပြောသွားတယ်လို့ပေါ့နော် first trimester မှာဒီ 800 mg per day ပေးသည့်တိုင်အောင် confirm is safety for mother and fetus ဖြစ်ပါတယ် safety profile အရင်ကောင်းပါတယ်ဒါကြောင့်မလို့သူ့မှာ congenital anomalies တွေ not different in vaginal or oral progesterone ဖြစ်ပါတယ်ဒါကြောင့် synthetic ထက်စာရင် natural progesterone ကအဓိကတော့ကျွန်တော်ဒီ first trimester မှာပေးလို့ရပါတယ်ခင်ဗျဒီ vaginal progesterone use ကပေါ်တော့လေးခါကြည့်တဲ့အခါမှာ2009ကနေ2012 18ပေါ့သူတို့3ခါဒီ study လုပ်တဲ့အခါမှာ worldwide ပေါ့ worldwide human protection congress ကို study မှာဆိုရင်သူကတဖြည်းဖြည်းနဲ့ပို့ပြီးတော့အသုံးပြုတာများလာတာကိုတွေ့ရပါတယ်ခင်ဗျဒါကတော့ luteal start vaginal micronized progesterone improve pregnancy success in women with recurrent pregnancy loss ဖြစ်ပါတယ်ဒီမှာတော့ဘယ်လိုပေးရမလဲဆိုတော့ Dydrogesterone vaginal capsule 100 or 200 mg 2 times a day with associated with improved pregnancy success in strictly cohort defined women with recurrent pregnancy loss ဖြစ်ပါတယ်အဲ့တော့ in pregnancy loss ဖြစ်ဘူးတဲ့ history ရှိတဲ့သူတွေမှာ ဒီ vaginal progesterone ကိုပေးမယ်ဆိုရင်ပေါ့နော် especially ဒီ first trimester တွေကပေးထားမယ်ဆိုရင် pregnancy loss ကိုsuccess ဖြစ်ပါတယ်ခုနပြောသလိုပဲ safety profile အနေနဲ့ပြောမယ်ဆိုရင် mother နဲ့ fetus ပေါ်မှာ safety profile high safety profile ဖြစ်ပါတယ် especially embryo toxicity တို့ dydrogesterone တို့မရှိတဲ့အပြင်ကို maternal weight embryo fetal viability and malformation တွေလည်းမရှိပါဘူးဒါကြောင့်မလို့ dydrogesterone ကိုကျွန်တော်တို့ဒီ pregnancy category A အနေနဲ့သတ်မှတ်ထားပါတယ်dydrogesterone is the best for history of one previous preterm but before week 34 also the uterus malformation condensation of surface short surface လို့ case မျိုးတွေမှာဆို dydrogesterone ကိုစောနိုင်သမျှစောစောသုံးရင် preterm birth ကိုအကာအကွယ်ပေးတာဖြစ်ပါတယ်ဒါလေးက remind ပါခင်ဗျာ preterm birth ရဲ့အဓိက prevention မှာ dosage အနေနဲ့ကတော့ from 20 to 36 week of pregnancy 200 mg once daily per vagina ဖြစ်ပါတယ်ဒါလေးကတော့မှတ်လို့လွယ်တာပေါ့နော် dydrogesterone ကိုကျွန်တော် magic number of dydrogesterone အနေနဲ့ပြောတာရှိပါတယ် once a day 200 mg a day 3 benefit safety efficacy and specific indication so the 42% preterm rate reduction and 50% neonatal mortality rate reduction ဖြစ်ပါတယ်ဒါကြောင့်မလို့ natural micronized progesterone ဒီ early pregnancy ကနေစပြီးတော့ throughout the pregnancy မှာလိုအပ်ရင်လိုအပ်တယ်လို့ပေါ့နော်စိတ်ချလက်ချသုံးနိုင်တဲ့ high safety profile natural progesterone ဆေးပဲဖြစ်ပါတယ်ကျွန်တော် presentation တော့ဒီလောက်ပါပဲခင်ဗျာကျေးဇူးတင်ပါတယ် The next session will be appreciation remark given by Dr. Nahan, Sales and Marketing Head, Pacific A Medical Products Limited. So I would like to invite Dr. Nahan to give the appreciation remark. Thank you.
Good afternoon. I'm Sana Ham from AA Medical Product Limited. On behalf of Benson's Healthcare and AA Medical Product Limited, I would like to extend our heartfelt gratitude to Chairperson CRG Aung, the guest speaker Dr. Prof, Mr. Richard Jeremy, Regional Business Director of Asia from Benson's, Mama Documenting, Presidents of Uji Society, as well as all the distinguished guests who graced the occasion. Thank you, all of your invaluable contributions to making today's symposium a success. We wish you all the pleasant day and see you next time. Thank you.